Good afternoon, everyone. My name is Sharon Rounds, and I'm the PI for Advance-CTR, which is a research enhancement program funded by the National Institute of General Medical Science and a collaboration of the Brown University, the University of Rhode Island, and the affiliated hospital systems, as well as the Rhode Island Quality Institute. Advance-CTR has had a monthly research seminar program now for several years. And this year we decided to change the format of the program somewhat and have a year-long seminar series where distinguished clinical and translational research scientists from our institutions present their work and provide us with insight into all of the really truly exciting work that's going on at our institutions, and we're very, very pleased to be able to launch this seminar series this year. This month, we're very pleased that our inaugural speaker is Eleftherios Mylonakis. Eleftherios is the Charles C.J. Carpenter Professor of Infectious Disease at Brown University. And among his many titles, he's Chief of Infectious Diseases at Rhode Island and Miriam hospitals. He directs the COBRE Center for Antimicrobial Resistance and Therapeutic Discovery. And he's Assistant Dean for Outpatient Investigations at the Alpert Medical School, as well as Director of the newly funded Center for Outpatient and Longitudinal Medical Research at the Alpert Medical School. Eleftherios did his medical training in Greece. He was a resident and chief resident here in Rhode Island at the Miriam Hospital and the Providence VA. He then went for infectious disease training at the Mass General at Harvard and joined the faculty there. But he returned, fortunately, to Rhode Island a few years ago and to lead the infectious disease division here. So we're really, really pleased to welcome Eleftherios, who's going to be talking to us about SARS-CoV-2 and potential pandemic pathogens and opportunities for clinical and translational research. So thank you very much, Eleftherios.
Thank you, Sharon, and thank you for the kind invitation and the very generous introduction. We have a lot to cover, so we'll be on a fast pace, but hopefully it would be interesting. Certainly it's going to be exciting from my end to share some thoughts about COVID-19 and how that can open up the field for what we can provide and how we can differentiate as a statewide infrastructure towards biomedicine research. Sharon asked me to start by providing some thoughts of the reasons behind this work and why we decided to pursue that area of study. And obviously, this is more of a discussion for and the thought for the more junior people. And the way that I would approach it is that we all have a why. We all have a why that we find early in our life of why we are going to do what we are doing. So that why you should listen to, and it will take you throughout the life. Usually we don't change the why we do what we do. What we change is our approach to what we are doing. The why for most people in medicine and biomedical sciences is trying to help people. So it's a very obvious why we do what we do. That motivates us, that, you know, people, everybody on this call works long hours, certainly a difficult situation, especially during a pandemic. What changes is the way that we approach it. And the way that I have evolved my thinking of how to approach my why is thinking more of the problem first and then try to find ways to answer it. When I was earlier stage of my career, I was trying to go from what I have, the tools that I have, to solve a problem. And then I realized that for a number of reasons that it's better if I go to the problem and then I try to find the tools. And the problem in this case, it's a pandemic. So it was a pretty obvious problem. It touched all of us in many, many different ways. And we all have great pains and painful memories from that COVID-19. So we saw that as Heraclitus, who was a pre-Socratic Stoic, a very wise person, said that the only constant in life is change. So embrace change, embrace the changes that we are going to go into the fields of your study, embrace the changes on the things that you're going to study. In our study, the COVID-19 provided some thoughts of how to approach that and how to use new tools. Early in the pandemic, we were all mesmerized of those patients who were coming to us. It was one day that we were seriously thinking about closing down all the main tower of the Rhode Island Hospital to make it a COVID-19. So put the filtration, the HEPA filters, to cover the whole hospital. The whole hospital, the whole main building was going to become a COVID-19 ward. There was nothing else that was going on, and there were days that we, frankly, we didn't know what to do with the bodies that would come from nursing homes and the outpatient facilities mostly, that were so impacted, and they were overwhelming our ability to handle them. This was heartbreaking. So trying to make some sense of where this is coming from, we used a mapping analysis where we tried to map the areas in a very small range, almost less than a city square, and try to see where to predict those. And we realized that most of them are coming from Providence, and most of them come from the same center, the same areas that we used to see influenza come from. So that gave us some mapping of where to expect that Providence is going to be mostly hit from the rest of the state, a small state, but still you saw a geographic location in the Providence area, and also that this is a respiratory infection that is going to impact the same people that were impacted from influenza. And here you see we were able to go to 3 different layers. So we realized that it was 3 different epidemics that were going on based on the age groupings. It was a younger age, and that is mapping all the positive COVID-19 and influenza reports that we had during the first 3 or 4 months of the pandemic, first wave of the pandemic, mapping them throughout the state, positive in any of the lifespan outpatient or inpatient facilities. So there were 3 layers of the pandemic. There was based on the age groups, and those were in different parts of the state, in different parts of Providence. I don't want to go into details, but one part that has to do with that was also had to do with the overrepresented Hispanic and Latino population that we had impacted in the early stages of the pandemic, the first and probably the second wave, and that was disproportionately a part of the patients that we would see. The Latino and population in Rhode Island is about 20%. And among the cases who were in the hospital, it was 40%. So it was double the number or the percentage in the hospitalized COVID-19 individuals versus what it was in the community. And of course, you can understand the socioeconomic ramifications of that. So that gave us start getting a handle of the population, how to use this information. 5 of our physicians were kind enough, they realized the problem, and they went out to Hispanic radio stations and other networking infrastructures, and they tried to alert people about this problem, tried to prime them when the vaccine became available, things of that sort that really reversed that trend. So you can take that information, you can have enough information in your data sets, you can use it, you can start realizing the situation, and you can start making it actionable in the way that you can approach and help your community. Another part was trying to make sense of what are the patients who are going to get worse. One of our little contribution was the first observation of obesity in the US, how obesity is associated with increased ICU admissions and resulted in higher severity of disease. Of course, now it's a given, but at that time, that was April of 2020 when this report was published. So early you can have an understanding of the disease, and you can understand that BMI over 35 is going to cause problems, because when you have few beds and large numbers of patients, you have to triage people, you have to alert people, you have to get them to a more intensive level of care earlier. So having some predictors, and we'll talk about it in a more detail, some predictors of severity can help you triage patients. But now we're having a wave. So the goal here is going to be to go from and try to present things that we have worked on, and also give you an update of COVID-19 of the COVID-19 pandemic. So we don't know how it's going to work, but this is my slide to transition from our epidemiologic and related work to what is going on now. So we since the first wave, we have a series of waves that were resulted from the ability of the virus, obviously, to change its spike protein in a way that is not predictable. That is the problem. We don't have the predictability that we have with influenza. Omicron, for example, was a completely different, out of the blue kind of mutation, series of mutations that really came out of did not come out of a progression from alpha to beta to gamma to all those letters of the Greek alphabet now that you all know. But Omicron came on its own. And the result of that is many mutations that change the ability of our immune system or the monoclonal antibodies or other treatments to fight the infection. And you see here how those mutations in the Omicron, in the initial Omicron, impacted both the part of the spike that associates with the human receptor and the rest of the spike. And obviously, as those variants become more transmissible, then they quickly take over. This is what the last time that we saw that it was with BA4 and BA5. And BA4 and BA5, we talk to them essentially in the same way because the spike is not very different. So what vaccine works for 4 will work for 5. What antibody will work for 4 will work for 5. So that's why you see 4 and 5 grouped together. And the next one that we're going to talk about, and it looks like it might replace 4 and 5, is BA2.75. And we're going to have a couple of slides for that. But here the point is that still with BA4, BA5, we are not stagnant. We're expecting more, probably the BA2.75 to become prominent and continue this ongoing evolutionary change or whatever you call it, change of the virus and the change of the ability of the immune system to fight it. A big question that happens, and of course we don't have a good grasp, is where those variants are coming from. It can be a reverse zoonosis where there is an unknown or many unknowns, animal reservoirs where we have the virus go there, mutate quite a lot, and then come back to humans. Or we can have a long incubation in immunocompromised patients, or it can be a part of what we do as humans with the vaccines, with antivirals, and we might be aiding that change of the virus. So far, it looks like the most likely diagnosis is the long incubation period of the virus. It looks like it can survive for hundreds of days, especially in patients with with compromised immune system, and it can spread around the body where it hides, even if it causes minimal or no symptoms, and then of course go through transition in order to survive the immune system and then become more transmissible. There is a case from Connecticut where the virus was present a year out of the initial infection in compromised host. So the virus continues to exist in some cases. Maybe that has to do something with long COVID. We don't know that. We'll talk about it in a second, but that probably feeds the changes of the virus. And of course, that results in a limited cross-variant immunity that of course results in the changes in our ability of the vaccine-induced immunity or post-infectious immunity to fight another variant. The mapping that researchers are trying to do is explained here, where we have the initial variant in the middle, and then they try to spread them out. How that the subsequent variants are related as far as the immune response to that initial virus. So that obviously links us to the vaccines. So vaccines, different vaccines now, and this is very typical because a lot of you will be thinking about the new bivalent vaccine that actually started this week and became available. I know that I have my appointment this afternoon, so and I will ask you to consider strongly about making your appointment as soon as possible. So we have different vaccines now. There is the Novavax, which is now the last addition to the armamentarium that we have, the viral vector, the Johnson & Johnson that is not used unless there is a specific reason for that, and the mRNA vaccines that are the most commonly used. Unfortunately, we have limited penetration now in the ability of even people who should have the additional boosters receive the boosters. For example, only 25% of the population that is over 50 years old got a second booster dose so far. And hopefully the new bivalent vaccine, this is going to change. You see the daily trends in doses of COVID-19 vaccine. So at some point over the April of 22, people decided that the COVID-19 it doesn't exist. Obviously, this is not the ideal way to handle things. Here is the dramatic difference that you see in the ability to have immune response that at least prevents symptomatic infection or hospitalization. You see that the third dose and you see the fourth dose, a clear difference from the time of you get the third dose, the time you get the fourth dose, clear difference, the boosting of the vaccines. Now we believe that about 6 months out of vaccination, you start to lose the ability to fight your ability to fight and decrease your chance of severe infection start to decline. So the vaccine is for at least 6 months works fine, and then from there on depends on your immunity, depends on the variants, depends on a number of things. The question, of course, is the side effects of the vaccines. Myocarditis is another area where other scientists could be able to contribute, and that is one area that it looks. There is a very interesting report that came out last week. I don't have a slide for that, but it showed that for people, especially women, and especially those who are 50 years or older, and have infection with COVID-19, even if that infection is not severe enough to get them to the hospital, the MRI of the heart MRI can continue to be abnormal a year out. A year out, you can have inflammation that is still ongoing. So yes, myocarditis from the vaccine is a concern, but it's very uncommon, especially in people over 20, 21 years of age. It's very uncommon. It is almost always benign versus getting infection with COVID-19, with SARS-CoV-2 that can result in myocardial abnormalities a year out with symptomatology, shortness of breath, etc. So the summary of where we are with the vaccines continues to evolve. The virus, BA.5, it's a 3.3-fold lower vaccine titers, ability of the titers to fight the BA.5 because of the evolutionary change in the spike, increased immune escape, and so the original vaccine was lower and wanes faster with Omicron. So we needed adapted vaccines. Vaccines have been effective against severe Omicron illness. So even if you have a booster with the initial, based on the initial virus, that will protect you, but it's better to get the bivalent that, as I said before, it became available. That was the slide from the ACIP meeting last week, that it was almost a unanimous vote to go to boosters with the bivalent that includes the initial mRNA vaccine from the initial virus and the BA.5. So you have the bivalent is available now, make your appointment. It's certainly going to be prudent to have it done sooner than later. What we don't know is the rate of myocarditis with the bivalent, because like the flu vaccines that we do every year, we don't do clinical trials with the flu vaccinations every year. The same thing with the bivalent vaccine. There was no clinical trials before that, so we don't know the myocarditis, but we expect that it's going to be low. It's an incremental increase in vaccine effectiveness it provides, but we don't know exactly the protection that we're going to have in the duration. There is a hypothesis that we might be able to go for a year with just a yearly booster, but this is a hope now. And the duration of protection, as I said, the hope is that we're not going to only need it for a year, and that will protect us from severe infection for 12 months for the next 12 months. But don't forget that even the immunity from the infection goes down and starts going down about 6 months as well. So even if you have an infection, the immunity fades away quickly, depends on the variant that you were infected in, the variant that is now, but at the most it will last for a few weeks. One problem here is what are you going to do with people who had an infection before, and when is the best time to vaccinate? And I use this example in order to tell you that not all the trials are easy to do in a pandemic. And this was and of course, we learn a lot with the difficulties more than we learn from successes sometimes. So this was a report that we published a couple of weeks ago that describes the difficulty that we have had with trying to do a large international study on evaluating the optimal timing of the vaccine for people after infection. So the goal was to differentiate patients and who severe infection with severe COVID-19, severe enough to get them to the hospital. Then some of them got a booster or a vaccination right after the infection. Some of them deferred to get the vaccination a few months later after the infection was after the immune system had completely recovered. But they're it's difficult. Sites around the country and around the globe had difficulty participating. Everybody is exhausted nowadays. So for 73 sites initially expressed interest, 30 opened and only 19 enrolled the patient. And then you have attrition of the patients month by month, and you see that the patients start to decline and the numbers, and you have to try and run after the wave. The vaccination guidelines change all over the place. The policies change. So it's very easy for us to say, oh, I want optimal data in order to make a decision. I want to know the percentage of myocarditis. I want to know the efficacy. I want to know the duration. Yes, but those studies are difficult to do, and we don't have time for that. And then at the same time, the policies change. So at some point, the airlines wouldn't board someone unless they had the documented vaccinations, etc. Working within the regulatory framework and limited incentives. The people also, our patients, were exhausted. They didn't want to participate. And the vaccine availability, even now, the booster that we are going to have, the bivalent in the US is different from the bivalent in almost every other country in the world. The bivalent and the boosters for Europe, Canada, and other countries is going to be based on the BA1, the initial Omicron. And ours is 5. So how can you do studies? How you can evaluate data? How you can evaluate efficacy? How you can evaluate everything else? So it takes years and months and months and months to go through those regulatory difficulties to put a study together. So you have to understand that you have to deal with a lot of uncertainty, and that is one of the things that I want to point out here. And the other part is the vaccinations beliefs. For us, it was much easier to enroll patients on clinical trials where we infused them monoclonal antibodies that were all manufactured in a lab, versus telling them that we're going to give you a vaccine so your body can make those antibodies. So sometimes human nature, it's extremely difficult to comprehend. And this is one of those cases. This can be a whole topic of investigation for people to try to understand what makes those beliefs and what can help drive change when there is an anti-vax movement nowadays. So reasons given for refusal, you see that from the patients that we approached, the second reason is some of them did not want to wait. Some of them did not want to get vaccinated. The second and the third reasons, most common reasons for people not wanting to participate in vaccinations. Some of them really want the vaccine as soon as possible, even if there is limited data. Some people never want it. And of course, serial trials and people are exhausted from participating in serial trials, especially people with COVID-19. So the clinical aspects, now we have to start moving and thinking of COVID-19 as a systemic infection. And we are really at the early stages of understanding that and appreciating that. Still, our thinking is, this is a pulmonary disease, this is a pulmonary disease, but now trying to understand the overall inflammation and how that impacts the body from MI to creating thrombus, to creating the myocardial injury that I described before. That is going to be, I think, the next level of understanding of how a respiratory virus like this can cause a systemic infection and a systemic problem. This is going to be, in my opinion, key in order to understand the organ involvement that we see, that spreads everywhere, the microclots and the platelet activation process that we start to appreciate now, and these surprising cases of emboli. Key in the future for that other investigators that are working in this field, I expect, are going to study is, of course, the long-term effects to the brain and the central nervous system. I think in some cases, obviously, we see inflammation of the brain. There, anosmia was a prime example of symptomatology in the early stages. So how the brain is impacted by infection and which population is impacted, and the long-term ramifications, we're just starting to scratch the understanding of that part. This is not our work, obviously, but I want to point that out. Long-term cardiovascular outcomes, as I said before, a year out, your MRI can be different, and large population studies have shown that the MIs are more common and arrhythmias are more common in this population post-COVID-19. So we have a long-term effects of COVID that are now we have at least 50 long-term effects of COVID that we are starting to at least try to put in boxes and try to make it classes. And it seems that some of them coalesce around different groupings. And that is, of course, as I said before, we haven't done this work, but this is important here. The risk of developing what we now call post-acute COVID, long COVID, it will become something more real than this very descriptive term, increases the more times that you get COVID. So there is a clear benefit, even if COVID now post-vaccination is going to be less acute and you avoid severe infection and hospitalization, still you don't want to get it. Still you don't want to get it because the more times that you get, and this is the CDC estimation, is you're going to get long COVID at some point. And here is the incidence of how your long COVID increases by the number of times. So the CDC estimates that if you get COVID about 8 or 9 times, and COVID is not going to go anywhere. COVID is not going to go anywhere. So if you get 8 or 9 times, you have about 85% chance of developing long COVID. So there is still benefit of taking common sense measures to avoid COVID, even if you are vaccinated and you're healthy and you have no predisposing factors and you're certain that you're not going to have a severe infection. There is one thing that you can do in order to decrease all the myocardial infection, ischemic injury, long COVID ramification. It looks like there is one tool to decrease your chances of getting all those things. Vaccinate yourself. Even if you get a long COVID post-vaccination that is milder and is less frequent among individuals who are up to date with their vaccines. So again, make the appointment to go and get the bivalent vaccine or start the vaccination. So treatment. Where are we? So how can you use treatment in order to make sense of what you're doing? And here we'll go back to our approach, and then we'll go back to what is going on now. So early on, we used our data again, trying to do comparisons and couple 1 to 2 or 1 to 3 case to historical controls ratios to see if remdesivir works. We found a benefit for remdesivir in our patients, and that helped us push remdesivir small benefit, but really a statistically important one. So not very significant. We used hydroxychloroquine. We remember all that fiasco early on. Not us, but about 30 patients. We compared them with controls. We found no difference. We stopped using it. And then we stopped listening to that nonsense once and for all. Convalescent plasma, we did the same thing. We found that it doesn't help, at least in the inpatient service. So that was another way of stopping the trial. Part of large clinical trials, we were able to evaluate other trials like this is ensovimab, is a protein that is made by E. coli. So you can teach E. coli to make this protein that is like a monoclonal antibody. So it's monoclonal antibodies that can be made by E. coli. So you can upscale it. It's not as costly. It's proven to work in outpatients, but in this multi-center trial that we were involved, it didn't benefit inpatients. So that is very important. So what is the difference? And now we start to realize that there is some precision medicine approach, that there is a continuity of infection that happens, and at some point, the infection is not the driving force, but is inflammatory response that takes over. That is not very different. That's not very unique. That is pretty much what is going on with other bacterial infections. With bacterial infections, if you let them go without treatment. Sepsis at some point is driven not because of the bacteria so much, but because of or candida or whatever is there, but it's driven by the inflammatory response. It seems that there is something similar, and there is an inflammatory response that happens here that at some point takes over and drives the disease, even if you use an antiviral. And this is the slide to link us to what we did here. We found this compound that is not FDA approved, but is used in other areas. Interesting how we got that, but this is not the point here. This improves the T cells. So it starts boosts the T cell, the CD4 count earlier. So this is a protein that it's made by the thymus. This is the similar peptide that to that, and that's Rhode has. And then we did a trial here, a pilot trial in our hands. It was FDA approved, and we found that indeed it boosts the T cells, and especially of people who are on high flow oxygen. So we have outpatient, inpatient no oxygen, inpatient on oxygen, low flow, high flow, intubated, ECMO. That is the continuity, and unfortunately death. That is the continuity of the infection when people progress, usually. And we see that also has not only boosts the T cells that we see on the lower right corner, but also that is related to clinical improvement. So some promising finding. If you have a lymphocytopenia, which is about half of our patients with COVID-19, then you can boost their T cells, and it looks like this might have a positive response. Now, I told you that we're going to talk about BA.2.75, which is the new variant. It's the first variant that seems that it can outpace the BA.4 and BA.5. Though that is still early, you might be seeing it in the near future, but in India and other places, it outpaces BA.5. But the good thing is that it has a similar neutralizing abilities as BA.5. So the bivalent vaccine should work. Unfortunately, the monoclonals do not work with most Omicron, most monoclonals. Only one, the new Lilly product, the most recent one, seems to work for some treatment options for monoclonals. But what it works, and also another study that is interesting here, monoclonals, once the virus stops mutating and we catch up with the monoclonals, it looks like the monoclonals will be able to work on patients who have not responded to vaccination. All the benefit from monoclonals appears to be only on the patients who had no antibodies of their own. Here is the graph of this multicenter trial with the Regeneron monoclonals. We were part of this trial. And you see here that the mortality is about twice as high for patients who had monoclonals, and you can get it down to the same levels as the people who had responded to vaccine or previous infection or to this infection and had their own antibodies. One interesting part is the post-Paxlovid effect, and I'm going to get a couple of slides because I think it's very interesting and very common, and there is a lot of discussion about it since Fauci also had a post-Paxlovid rebound. So this is people who develop COVID-19, get the Paxlovid as outpatients, then 5 days later they are negative, they feel better, they end their course of 5 days treatment, and then a day or 2 or 3 after that, they have a rebound. And that is a virological rebound, so become positive again, or clinical rebound. And Tony Fauci also had the same problem, and that's why he's here. We know that the benefit from Paxlovid stays. So even if you have a rebound, those first of all, it's a non-linear disease, so you have rebounds regardless if you are on Paxlovid or not. But also, even with that understanding, still oral treatment will decrease your chances of coming to the hospital by 80%. So still advocates for people who can use it to use it. Still drug-drug interaction that should be taken into account. We looked at it's a virological rebound. It can happen without Paxlovid, so you know it's a non-linear disease, as I said. And then we don't know who is at high risk or if it promotes drug resistance and other parts of the rebound. And we don't know if a second course of Paxlovid would be beneficial or not. So we are now trying to transition from pandemic to endemic, and I'm going to this is, I think, where we are right now, and that is the hope where we're going to go. Hopefully, we're going to stop having those waves, and we're going to become to a pattern like the influenza. So SARS-CoV-2 is not going to go anywhere, unfortunately, but at least it's going to be more predictable. And this is a study where we were involved. You need to have, as I told you before, a way to evaluate who is going to be severely ill or not. And that is descriptive, older, obesity, diabetes, immunosuppression, those things. But those are not very specific as much as you would like them to be. And also the viral load of the airway depends on the subvariant, depends on the sample in some degree, so that has not been very reliable as well. But this study evaluated the plasma antigen level, not the antibody level, the antigen, and found that really it might be a way to predict the patients, among the patients who are hospitalized, who is going to get worse. So there is a threshold of 1,000 particles that really as a viral load that predicted patients who are going to decline, that progression that I mentioned before of more oxygen and intubation and everything else. So that was quite interesting. So and for people who are on the HIV realm, of course, viral load of the bloodstream is part of the common, part of what is done and used to evaluate patients. Is not a one-to-one. But it helps diversify people who have a higher viral load, probably will progress faster. So So this is probably going to be a tool in the future to use it in clinical decision making. So we don't know it, also the epidemiology of the virus, if it's going to have the pattern of influenza, or if it's going to be year-round. Coronaviruses usually don't have an annual pattern, unfortunately. So we are in the process of transition from pandemic to endemic. So it's not going to go away. It's a wonderful field to study of trying to understand how a virus can come into humans and how it has many different ramifications, from immunity to brain to long term to pulmonary disease. Also, the downstream ramifications of drug-drug resistance increased with COVID-19. Many reasons for that, not the point to make it. Acute hepatitis, other ramifications obviously increased. So the conclusion is that this is a village that needs to coalesce around it. I gave you some food for thought, how we can use even simple tools and our data in order to try and fight it. Try to go to nursing homes or post-acute care facilities. That's what Sharon and I are trying to do now with this initiative for the Center of Longitudinal Care, try to see how that is handled there. And the Division of Geriatrics is a very good program of trying to evaluate vaccination in this population. And Stefan is doing a phenomenal job in that. And then the other ideas that I tried to share with you. Marcus Aurelius, also a Stoic, said that an infected, he lived 16 of the 19 years that he was the emperor of the Roman Empire. There was a pandemic. So his point there was an infected mind is far more dangerous than any plague. So let's try to keep our mind clear of that, and then try to help as many people as we can. Thank you. I guess we can.
Thank you so much. Yay. We have a question in the chat. Ira Wilson asks, could you comment on the relative importance of cellular and humoral immunity in the response to SARS-CoV-2?
Yeah, and the T-cell immunity is something that it's still understudied. We know that if you have leukocytopenia with your T-cells being down, as I said before, you are going to have worse prognosis. You're more likely to progress in COVID-19. However, the exact role of the T-cell immunity in the long term is unclear at the moment. The best that we can say, there are different opinions of the significance. It doesn't, and I'll stop there.
Steve Kogut asks the $64,000 question. What is the likelihood that a highly evasive variant will emerge and send us back to square one or worse? With inflation, I think the $64,000, we have to increase that part. But it's unlikely. It's unlikely for a variant that is going to be so completely able to evade all our immunities. Even if you have remote vaccination, you do have some protection. It's low. You should get your booster. You should get the updated vaccines. But there is, and of course, we moved away from what some people would say herd immunity. Of course, there is no such thing, but there is some protection that exists. We have oral agents. There are antivirals that are under study. There are some monoclonals which eventually will catch up. We have vaccines that we updated, with some delay, but still we can update vaccines now. We have a second generation vaccines for a disease that didn't exist 3 years ago. Yeah. So this is remarkable. I went online and I had an appointment for a vaccine
for the second generation of a vaccine that of a disease that did not exist 3 years ago. This is unimaginable. So I'm optimistic, but there is a lot to learn still.
So how has the fast pace and the pressure imposed by the pandemic changed the way in which clinical trials are performed? Do you think this will have a lasting effect on the performance of trials, perhaps for other conditions as well?
Yeah, there is one element that appears to be more powerful than the pandemic, and that is bureaucracy. That is an unbelievable, immovable object that does not understand the pace of a virus. It's there, and it's impossible to change. So trying to deal with the FDA, trying to deal with policymakers and try to expedite those parts is extremely difficult. And I haven't seen a lot of change there. Investigators were able to coalesce quickly and come together and produce great science. We know so much about COVID-19 now, 2 years into it, that is so ingrained into our thinking process. Nevertheless, I haven't seen, so I'm afraid that not much change has been made. And I'm not that part fighting through bureaucracy looks impossible.
Have you noticed a difference between the responses of pediatric primary immunodeficient patients as opposed to adults with immunodeficiency conditions?
I don't see pediatrics. We did treat a number of children earlier with the Delta variant. We were able to be one of the handful of centers that infused the children with monoclonal antibodies, and we had people, immunosuppressed children who drove here from Atlanta, from upstate New York, from Indiana, just to get the infusion and go back. All of them did very well. We had a couple of dozen children and wonderful experiences from that. Overall, immunodeficiency and of course the vaccination is not, it's a different timing for vaccination, and the vaccine became available to young children in different time points. I would say that immune suppression, that population is the victim, the long-lasting victim of that, because no one is masking now. We are going to get the vaccines, but we have a dilemma now to people who don't mount an immune response to the vaccine. Either they're going to be socially isolated or risk their severe COVID-19, and that is unfortunate. I wish we would all keep wearing our masks, even if we're vaccinated, even if we don't belong to high-risk populations. But in order to protect our immunosuppressed members of our community, unfortunately, that it doesn't seem that this is going to happen.
Interesting. So any other questions from our audience? Here's one. Attila Sehan asks, do we have the scientific tools, the policy, and the global cooperation to deal with the potential future pandemics better than before? We may have these types of events occurring more frequently due to climate change, loss of natural habitats, and other factors.
Yeah, I agree with both parts here. The second part needs to be highlighted, that we had SARS, We had the flu pandemic about 12 years ago. We had SARS-CoV-2, and of course, even recently we had monkeypox and other concerning outbreaks. So indeed, this is happening with some frequency and increased frequency. So there is no question that this is going to be part of our experiences in the future. Now, if we have the tools, the way that I observe it, we are better now than the completely unprepared situation that we were before. But still, the basis of a global response means that we put everybody on a common field and we try to do the best that we can. And we don't break into what is best for me individually, what is best for my country, what is best for my people who are going to vote for me, what do they want. I haven't seen this coming togetherness that is needed for a real global response. People are going to wear a mask if they're afraid. People are not going to wear a mask, and it's just an individual response. Countries protect their own people. Political parties here listen to what their people say, and they embrace sometimes anti-vax policies based in order to appease their voters. You see those things that really the cohesiveness is lacking.
Got it. So that cohesiveness would be an important tool going forward.
Cohesiveness comes either from the bottom or from the top. From the bottom, people are very difficult to organize, although social media should be able to push towards that, but it hasn't worked. From the top, we don't have a leading agency. Even WHO came out of this pandemic with less prestige than it entered. So we don't have a leader to lead that international response. That's my reading.
Okay, interesting. And James Salenza asks, what role do you still see for NPIs, masking, vent, avoiding large assemblies indoors?
I think that this is an area where there is medicine and there is social sciences, and that can be outside of medicine. But for me, I don't see a problem with masking. I don't understand what is the problem with putting on a mask to protect somebody else. The numbers are dramatic in the way that if you put even a surgical mask, two people, you decrease by 3x the chances of transmitting the infection. So it's common sense. Now, large assemblies, I would say, again, using common sense, I think that unfortunately immunosuppressed individuals, especially those with high risk, should be very, very concerned about it. And then for other people who don't belong to those high risk populations, get the vaccine. There is one thing that you can do that depends on you: get the vaccine, the booster.
Great. Well, this is really great. And thank you again so much, Eleftherios. And I just want to say that next month, the second speaker in this series is going to be Carrie LaPlante from the School of Pharmacy, College of Pharmacy at the University of Rhode Island. And we're looking forward to her presentation as well. So please do complete our evaluation survey, which would be emailed to those of you who registered. And thanks to our wonderful inaugural speaker, to the staff of Advance-CTR, and to all of the engaged attendees. This was a really wonderful start to a new seminar series. So thanks, everybody. Signing off.